Alright, in this video, we will be discussing about how to evaluate a patient with jaundice. Suppose a patient comes to you in OPD and he brings a report of liver functions with you and tells you to evaluate the report, and you see that there are you see that there is isolated elevation of the bilirubin, means only bilirubin is elevated. SGOT, SGPT are normal. This is one scenario. Or maybe the patient comes to you with elevation of bilirubin as well as SGOT and SGPT as well as alkaline phosphatase GGT. So there are certain patterns of elevation of liver enzymes in a patient of jaundice, right? In these we have to decode these patterns because these patterns are seen in certain underlying causes, and the causes or the diseases, they cause a certain pattern of liver enzymes to be elevated. As far as jaundice is concerned, patient with jaundice is concerned, the evaluation starts with whether there is isolated elevation of the bilirubin. Very important to understand. Isolated elevation of bilirubin, or there is bilirubin plus other liver enzyme elevation. Right. So these are two scenarios. First of all, to start with, right, there is a particular flow chart or algorithm. We will, come to you in the next slide. But again, I have to emphasize that whenever the patient with jaundice comes to you, you have to just think about two things: whether isolated elevation of bilirubin or bilirubin plus other liver enzymes are also elevated, right? Okay, this is the flowchart or the algorithm that I have copied from Harrison's Principles of Internal Medicine textbook. We have to go through this algorithm in order to reach the cause, or in order to diagnose the patient with minimum number of investigations. So to start with, let me zoom in it a little. Yeah, this is okay. First of all, history, physical examination, lab test, AST, ALT, alkaline phosphatase, prothrombin time, and albumin. We have to do complete routine examination along with routine investigations along with history. Right, history may we have to look for medication and drug exposure, because certain drugs like acetaminophen, medicines like amoxicillin, valproic acid, and number of drugs, they cause different patterns of liver injury. Right. So isolated elevation of the bilirubin, if it is there, we have to look for whether it is direct or indirect hyperbilirubinemia. In the previous video, I have already discussed that we have to look at the direct fraction of the bilirubin only. If it is more than 15%, it is direct hyperbilirubinemia. If it is less than 15%, it is indirect hyperbilirubinemia. Right? More than 15%, less than 15%. Indirect, direct. Okay. If it is direct hyperbilirubinemia, there can only be two causes: Dubin-Johnson Rotor syndrome. Right? If there is indirect hyperbilirubinemia, the causes can be multiple. First of all, drugs. Which drugs cause isolated elevation of bilirubin? It is rifampicin and probenecid. Inherited disorders like Gilbert syndrome and Crigler-Najjar syndrome. And hemolytic disorders of ineffective erythropoiesis. For example, some myelodysplastic syndromes, or for example, vitamin B12 deficiency, etc. These all will cause hemolytic disorders. So, isolated elevation of the bilirubin is complete, I believe. If the patient comes to you with bilirubin and elevation of other liver enzymes also, this pattern is more common, right? Bilirubin and other liver tests. What are other liver tests? ALT, AST, alkaline phosphatase, gamma glutamyl transferase, right? These two are the markers of liver injury. These two are the markers of cholestasis. Whenever these enzymes are elevated, two patterns of liver injury are formed. First is the hepatocellular pattern, second is the cholestatic pattern, right? First of all, we will have a quick look at the algorithm, and then I will come on to the whiteboard to make you understand ki what are the different causes of different patterns of liver injury. Hepatocellular pattern, we have to look, how will you say it is hepatocellular pattern? It means AST, ALT are elevated more as compared to alkaline phosphatase. What is the normal level of alkaline phosphatase? It is 40. What is the normal level of ALT, ALP? It is 30 to 40. So now you must understand, you will be able to appreciate that if alkaline phosphatase is, for example, 50 or 60 and ALT is 500, we will say hepatocellular pattern. Causes of hepatocellular pattern are viral serologies. First of all, virology. Hepatitis A, B, C, D, E. Any hepatitis virus can cause hepatocellular liver injury. But these three are more common. A, B, and C are more common. So we will do these markers initially. Then toxicology screen for acetaminophen, paracetamol poisoning. Then Wilson disease. It is very common if the patient is less than 40 years of age, right? Then ANA, smooth muscle antibody, and serum protein electrophoresis, right? ANA, SMA are for autoimmune hepatitis. SPEP is to look for immunoglobulin G or gamma globulin component of liver globulins of serum globulins. It is a different topic in itself, but serum protein electrophoresis is done to estimate the amounts of globulins in the blood. In autoimmune hepatitis, globulins are elevated. That is why we do these three tests, ANA, SMA, and SPEP, just to look out for the cause of autoimmune hepatitis. I mean, to rule out autoimmune hepatitis. If these tests are negative, we will do additional tests like means less common diseases, cytomegalovirus, Epstein-Barr virus, hepatitis D, hepatitis E. And if everything is negative, go for liver biopsy. And what are we studying? We are studying hepatocellular pattern. Now cholestatic pattern. Uh, the difference between cholestatic and hepatocellular pattern approach is that in cholestatic pattern, first investigation that you will do is ultrasound. It is not virology, it is not serology, it is ultrasound, and you look for dilatation of bile ducts. If bile ducts are dilated, means extrahepatic obstruction is there, and then you will do MRCP, ERCP, CT to look for a mass, to look for bile duct stones, to look for mass at the ample of Vater, etc. Means there is some kind of obstruction to the bile outflow. You will do further imaging. If ducts are not dilated, means the cholestatic is at the level of liver only, and that too at the level of cells only, means bile canaliculi are obstructed either due to edema or due to some other cause or due to some enzyme deficiency. The bile conjugated bilirubin is not able to reach the bile, or if it has reached the bile, it is not able to get excreted because bile is not getting mobilized. It is cholestasis. It is the stasis of bile, right? The causes are most important is autoimmune hepatitis, right? And some viruses like hepatitis A, CMV, EBV. It is very important to understand that any hepatitis virus, any hepatitis virus A से लेकर E तक can cause both hepatocellular pattern also, cholestatic pattern also, right? In this case, after doing ultrasound, if ultrasound is negative, we will do these tests. If AMA is positive, we have to do liver biopsy, and if the results are negative, again we have to do liver biopsy, but we can do MRCP first of all. Means if you do not find anything in serology, you have to go for liver biopsy, right? AMA is positive, liver biopsy is very very important. AMA means antimicrosomal and antimitochondrial antibody, and it is positive in primary biliary cirrhosis. And to make a diagnosis of primary biliary cirrhosis, we have to do biopsy, right? In other conditions, in if the serologies are all are negative, then the purpose of doing liver biopsy is something else. Then the purpose of doing liver biopsy is to make out the underlying cause. Here we know the underlying cause, we know it is uh, primary biliary cholangitis, so we do liver biopsy keeping in mind that diagnosis. Okay, hepatocellular pattern, you know, any virus, right? Anti-nuclear antibody, uh, ANCA, smooth muscle antibody, anti-liver cytosol antibody. Means autoimmune hepatitis को rule out करना है, drugs को rule out करना है. If it is negative, you have to go for biopsy, right? In cholestatic pattern, first investigation that you will do is ultrasound, right? If it is negative, you will go for serology. In serology, you will do virology, and primary biliary cholangitis के लिए we will do anti mitochondrial antibody. If it is negative, we go for biopsy, right? This is the basic approach of cholestatic and hepatocellular pattern. And remember, these two patterns are seen when bilirubin and other enzymes of liver are also elevated, right? Now, what are the causes of isolated hyperbilirubinemia? This is the chart from table from Harrison's. Indirect hyperbilirubinemia is hemolytic disorder, ineffective erythropoiesis, increased bilirubin production, and drugs. Inherited conditions also. Direct hyperbilirubinemia, only two causes: Dubin-Johnson, Rotor syndrome. These two are congenital. Hepatocellular injury, viral hepatitis, alcoholic hepatitis, chronic liver disease, drug toxicity, environmental toxins like vinyl chloride, kava, and pyrrolizidine alkaloids, amanita-phthaloids, right? Wilson disease, autoimmune hepatitis. These are the cause of hepatocellular conditions. Cholestatic conditions are multiple, and this is a long table in Harrison. I have divided this table into 3 slides, right? It was so large a table. So cholestatic pattern is caused by viral hepatitis, alcoholic hepatitis, drug toxicity, primary biliary cholangitis, primary sclerosing cholangitis, vanishing bile duct syndrome, congestive heart failure, and some inherited conditions like PFIC, progressive familial intrahepatic cholestasis, and BRIC, benign recurrent intrahepatic cholestasis. Another cause, pregnancy, TPN, right? Paraneoplastic syndrome, veno-occlusive disease, GVHD, TB, lymphoma, amyloid sarcoid, infections like malaria and leptospirosis, malignancy, cholangiocarcinoma, pancreas cancer, gallbladder cancer, ampullary cancer, benign conditions like choledocholitis, post-op strictures, primary sclerosing cholangitis, AIDS, Merizi syndrome, parasitic disease, etc. So these are all the causes of cholestatic liver injury. So I hope this you must have learned something valuable from this lecture. Most of the things were, you know, kind of factual. You have to, read them over and over again in order to remember them. But still, I think discussion of the topic makes the things a bit easier to learn. So that is why these kind of discussions are important. So that's all about this video. Thank you so very much.